Care of the Aging Adult. This is Martha Olson, Iowa Lakes Community College. We will be looking at the introduction to what gerontology nursing is, some of the population statistics, and theories related to aging. Our objective is to look at the unique roles of the nurse that works with the aging population, or the gerontological nurse, as provider of care and manager of care. We think about what attitudes we have as we work with the elderly and older adults, and think about what has shaped our attitudes. Maybe we have grandparents or older neighbors. Maybe you work in long-term care. What does the media say about the older adult population? Has your attitude changed as you've aged or maybe grown personally? As a provider of care, we know that's the direct hands-on care to older adults in a variety of settings. Older adults often present with atypical symptoms that complicate diagnosis and treatment. As we think about that statement, we think about the atypical symptoms such as a urinary tract infection, where that nurse in long-term care might notice the personality change or the confusion or restlessness that an older adult would exhibit, and know that they need to check for an infectious process, because older adults don't necessarily run a fever or have the typical signs and symptoms of a urinary tract infection that a younger person would. That is a good provider of care. As a manager of care, we look at the nurse that balances the concerns and works with family and other healthcare team members. The manager of care provides leadership, time management, communication skills, building of a trusting relationship, and maybe supervises other team members. And so as manager of care, maybe you're the director of nursing in a long-term care facility, or perhaps you are an RN working in a facility where you are delegating responsibilities and tasks to maybe nursing assistants or LPNs that you are working with. We also need to look at some of the core competencies needed by the nurse that works with the older population. As we look at certifications, we see the gerontological specialist, nurse practitioner. There's a lot of specializations and certifications that can be provided for the elderly population. As we look at that population, then we know that they live in a variety of settings. Most of them live at home, and that oftentimes is a myth when people will say that all old people live in nursing homes. Well, that is not true. The majority of our patients do live within their own home, and that's where they choose to live and want to live. 54% live with a spouse, 30% are widowed and live alone, and only 4% live in long-term care. As we look at the older adults, we know they will enter and exit the healthcare system at many different points. And when I say that, I think of being a hospital nurse and how many of our older patients come to us from their home, but after an injury, a disease, something going on, they are no longer able to go and live in their own home. And so the hospital sometimes becomes that point of entry into either assisted living or long-term care facilities. Assessment and charting is very important. As social workers and other people look at the data, it helps them to know where that patient would best go. You know, if they're having difficulty walking, they need oxygen, they're not able to, cook or climb stairs, maybe long-term care facilities would be a better decision. And so our charting helps to establish maybe where that patient would be best fit as soon as they're discharged. Our settings of care are listed here. We have lots of places where we take care of the elderly. When we think of these different places, the acute care hospital is very short term. Insurance companies and Medicare only allow so long for a stay. And so we have to, on admission, be already thinking about, are they going to be able to go home? Do they need a hospital bed and oxygen when they do get home? Or contacting, families and making decisions. Many times the patient in acute care will then go or be transferred to a skilled hospitalization, which they're in the same room in the same hospital. It's just a different level of care, because they either need physical therapy for strengthening, they need a longer time getting IV antibiotics, something is keeping them there. As we look at respite care, that can be either in the nursing home or in the hospital. Respite care is when a patient is cared for at home by their family, but the family needs a break, or maybe they have a granddaughter getting married out of town and they want to be gone for the weekend and there isn't anybody to care for dad who has Alzheimer's. So we bring them in, and usually they are self-pay when they're respite care, because there's no medical reason for them to be there except that we are just going to take care of them and keep them safe while the family has just a break away from the 24/7 cares that they are giving. Assisted living has really come around in the last few years. We know they live in a private room or an apartment, but they also have that community setting. Many times they will have meals together. They have Lifeline, they look after them, and so assisted living is kind of that step before the nursing home or before long-term care that helps them. Adult daycare is just like daycare that you would take a small child to. It's there for families that work or they have other obligations during the day, and their family member can go there and they have activities, they have a place for them to rest, and they keep them safe so that the family can have a life outside of their caregiving obligations to that person. The other thing we need to talk about is being an advocate. And as we look at clients and populations that are very vulnerable, we have to advocate as nurses for them. We want to promote what's in their best interest. We also want to empower them to remain independent, make their own decisions, and also retain their dignity. Who are those vulnerable people or the vulnerable populations? There are many, and we could spend a long time talking about them. There's a lot of statistics related to the aging in the U.S. Women, as far as gender, tend to be more vulnerable, especially the older ones that did not work and their husband made the income, and they are now widowed, and perhaps they have a limited income. Education, those that did not graduate high school, which there are many, lack some education. Socioeconomic status is related to that. With education, they have an above average health, and people that are of lower socioeconomic status and education tend to have lower average health. Older people who live alone are more likely than their married counterparts to live in poverty, because they only have one income. It's that one Medicare check coming in that has to pay the heat and the rent and all of the utilities that they have. In long-term care, only about 4.5% of older adults reside in long-term care, so that percentage is very low when we think about overall where are the older people living. But that percentage does increase with age, so a 70-year-old is not as likely as a 90-year-old to live in long-term care. By the time they get to be 85 years of age, about 18% of older adults do reside in a long-term care facility. So there's a lot of data and statistics looking at vulnerable populations. You don't need to know the numbers or the statistics. We're just thinking about, where as nurses are we going to care for these people or see them? It might be at dinner date where they gather once a day at noon to have a healthy meal and socialize. Maybe it's in public health when we are going out into their homes to do a dressing change for somebody that is living at home. The other group of population that we don't often think about is your inmates. The number of inmates over 55 is doubling and is increasing every 5 years. Their physiological age usually is about 10 to 15 years older than their biologically stated age, because they've either used drugs, alcohol, or had kind of a rough life, and so when we look at them we think they look older than their stated age. It costs 3 times as much money to care for older inmates than compared to the younger ones. And the older inmate tends to have at least 3 chronic health conditions. We also know that a very high percentage of your inmates have mental health disorders or mental illnesses that have to be treated. So there are a lot of implications for nursing as we look at many of the different places where these people are living and residing. The other objective we need to look at is our population-based issues for the aging adult. You know, where do they live? Do they all go south to Arizona and Texas for the winter and then come back? Some of them just locate down there and stay year-round. We know that centurions are making up some of the fastest growing segments of our population. We know that being a widow is more common, and women are more likely to live in poverty. So there are a lot of issues that relate with our older adult. When we look at the factors in the development of attitudes toward aging and the aged, we know that how we look at older adults is oftentimes how we were brought up. How did your parents and family look at, discuss, and respect older adults? Were they looked at very negatively as they're old and decrepit and they're always sick? Or do we look at that age of our population and say, they've contributed a lot, they have a lot to offer here? Sometimes when you go to Walmart and you see these very much older people still working, we know that there's a lot of very young and positive older adults out there amongst us in the community. So we are a result of our past and our past experiences, and we have to evaluate, do we have what we call ageism? Do we have a kind of a negative view of the older adult? When we look at statistics, again, you don't need to know these for the test or anything, but we just know that there are a lot of baby boomers that were born between 46 and 64 that are now getting into that age span where they are applying for Medicare and retiring. It's about 12% of our population, and we know that people are living longer because we have better nutrition, we have better medications that keep people alive longer, and many other factors that tell us that these numbers are going to only continue to increase. When we look at the diversity of older adults, we know that minorities are about 19%, and nurses' care of the older adult poses a lot of challenges that we'll be talking about in class and in our simulations because of the differences in physiological, cognitive, and psychosocial health that they all have. When we look at ageism, that is what I was referring to a minute ago when we look at that negative stereotype. All old people have dentures. All old people are demented. All older people are senile. They drive slow. Those are not true. There's a lot of discrimination, and we know that starting at about 50 when people apply for jobs and they're not granted the job or not given the job because it's assumed that people over 50 don't know how to use a computer, or they're not up on technology, or they're going to start having health problems because they're over 50, or they're going to start having problems with memory because they're getting older. That is discrimination, and we know many, many older people that have very healthy lives and do not experience any of those problems. Ageism is talked about as they're not working, so they're not worthy. Maybe their knowledge is outdated, and I can tell you from being around a lot of older people in my church, they are very smart. They have lived and they know history. They are very good with remembering facts and doing many, many things, and they have a lot of hobbies and outside interests. So think about how, as nurses, we can promote that positive image in nursing to get over people thinking about the elderly as negative and causing that ageism that continues on. So when we look at some of the things with successful aging, we have to think about what causes people, some of them, to be very young and very youthful and active and physically active, whereas other people at the same exact stated age have many disabilities and have so many losses in their life. In class, we'll be talking about diet and nutrition, and we've all had the nutrition class, so we know that diet plays a big part in that. Other stresses in life can add to how well somebody ages as well. Successful aging, there's really no definition of it, but we look at it socially with life satisfaction. I've accomplished the things in life that I want. I have good feelings of well-being and where I am at the age I'm at right now in life. Biomedically, we look at it's the absence of disease, that I'm healthy and I don't have diabetes and bad knees and some of those other problems that we sometimes see with the elderly. And then other identifying characteristics or predictors of old age. Poor health late in life is not inevitable. And there are modifiable risk factors that contribute to that. Smoking and alcohol are